All right, good morning, everyone, and welcome to day 2 of our first virtual symposium. Today, I'm going to talk about my research project, and the title of that is Characterizing Fine and Ultrafine Particle Exposure among a group of home healthcare workers. So one of the main research areas of the ERC is home healthcare. So that was the main focus of this project. Home healthcare workers are a set of workers that visit people in their homes, administer medications. They also do occupational therapy, which is the set of workers that we used for my project. The hallmark of successful healthcare delivery is dependent upon mostly the health of its own workers in order to keep their patients healthy as well. However, the health of home healthcare workers in particular is a relatively understudied area, even though some of the research has shown that they are more inclined to getting injuries from sharps, from bloodborne pathogens, from administering medications such as chemotherapy. Secondhand smoke is another risk factor, ergonomic risk factors, and even violence from the patients themselves. The home healthcare field is growing very rapidly, and the expected growth rate by 2024 is 60%. However, as I stated, the literature on the risk of these workers is limited. They do have a unique schedule because they visit multiple patients per day, so they're driving to and from these patients in their cars. However, currently there is no air pollution exposure data in this set of workers. So ultrafine particles are a size range of air pollution particulate matter. It's the smallest size particle, less than 100 nanometers in diameter. Most of the literature out there has suggested that ultrafines might be more toxic than their larger particles, and subsequently because of that could promote greater health risks. And one of the reasons for this is because of their small size, they have a much larger surface area to diameter ratio, which allows them to absorb more chemicals onto their surface, routing those to the human body if inhaled. They're also very highly spatially and temporally variable, and they decay quite rapidly from the source. They have been known to create reactive oxygen species in the body. They can deposit deep into the alveolar regions of the lungs, and they can even cross that air-blood barrier exchange and translocate to the blood and move on to other organs from there. The main sources of these ultrafine particles are combustion sources, and one of the main routes of that is diesel exhaust from traffic and cars. So anything that's combustion related is probably a good indication that they're generating particles in this size range, such as cooking, candle burning, anything wood burning. And in the literature, though it's not completely apparent whether or not they do promote greater health risks than their larger particles, some of the studies have shown that there's an increased risk of cardiovascular effects, such as an increase in blood pressure, a change in the vascular tone, and as well as decreases in heart rate variability. So with that, we came to what we thought was a research need in this area because of the time spent in cars for home healthcare workers, traveling to and from patients all day. They spend a lot of time in traffic, and therefore we thought maybe they were at an increased risk of particulate matter. Some studies have shown that there is a higher particulate matter exposure, especially in the transit microenvironment. This was shown in commercial truck drivers as well as bus drivers. In home healthcare workers, there is absolutely no literature on air pollution risk. And ultrafine particle-specific health outcomes in the literature are lacking. So it's unknown whether the health risks are due to the ultrafine size or the larger particles. There's a lot of conflicting results in the epidemiological literature because of the failure to measure concurrently ultrafines with the larger particles. There's also a lack of the use of personal monitors, and so they use stationary monitors to assess personal exposure. And there is also a lack of a standard exposure metric for ultrafines, whether that be the particle number, the lung deposited surface area, or the mass concentration. Studies use a wide variety of these three metrics to measure, so it's hard to compare results across studies. So with that, we thought that this was a good topic for my project and would create a significant research need. And so our hypothesis was that home healthcare workers would experience higher exposure to ultrafines, in particular during their transit times and in patients' homes compared to their own reference environment. And we did this, or we were planning to do this through a few specific aims. One of them was to just characterize the number of ultrafine particles among these different microenvironments. And then we wanted to determine if ultrafines were independently associated with specifically heart rate variability of the workers. And then we also wanted to hopefully look at the three different exposure metrics that were measured and see which one was more predictive of that heart rate variability. So one of the first things that we had to do for this project, this project started from scratch, and so there was a lot of involvement in recruitment, in recruiting partnerships with home healthcare companies, and finding those companies that were willing to work with us and let us recruit their workers. So when we finally did that, and we were able to recruit a few workers for the study, this is what the sampling session looked like when we were able to run the study. There was an initial study visit where they were consented, and they were given the equipment for the study, which included an ultrafine particle sensor called the Partector. They were also given a device called the Smartia device, not the MicroPEM, but that measures PM 2.5. And these are both personal monitoring devices, and they were situated in a vest that they could either wear or carry with them throughout the day. And then they also had a bioharness, a Zephyr bioharness to measure their heart rate variability that was attached to below their chest. And then they also had a smartphone to record GPS coordinates throughout their day. And so during the actual sampling session, they sampled for 5 days or 5 work days is what we preferred. They would turn it on an hour before they left for work. They would leave it on all day, and then they would turn it off an hour after work. And so we were able to capture ultrafines, PM 2.5 throughout the day, as well as humidity and temperature and that heart rate variability through the bioharness. They were also asked to complete a survey at the end of the day and after each patient to determine if there were any unusual sources of ultrafines that we might run into in the data. And then finally, we met with them, we collected the study equipment, and then we would give it to the next participant. And so we wanted to recruit hopefully 30 home healthcare workers through convenient sampling. And again, they measured ultrafines and particulate matter. The picture on the right is the Partector, so you can see kind of what it looks like and the size of it. In our analysis, we were looking to do descriptive analysis of the particles themselves, look at the correlations between the microenvironments, and then we wanted to run some linear regression models on ultrafines, on their impact on and their association with heart rate variability, as well as Poisson regressions to determine which was the most predictive exposure. So that was what we were hoping to do for the study, and due to COVID, we had to cut data collection short. And so unfortunately, we were only able to collect 3 participants for the study. And so the remainder of the results are mostly descriptive in the nature. So I'll share what we have at the moment. So this is a table of the 3 different participants' characteristics. As you can see, they were very similar in age, BMI, and amount of time that they've spent as a home health care worker. We did have 1 male in the study. So across the 3 subjects, we were able to capture a total of 156 hours worth of ultrafine particle data. And the average weekly ultrafine concentrations across all 3 subjects for the entire week was 2118 particles per centimeter cubed. And the mean of that was 11,000, which is pretty consistent across other studies for indoor concentrations. So the average lung deposited surface area for all the subject was 25.5 roughly, and there's also the mass concentration that we found. And then I was able to break down the weekly median ultrafine concentrations per subject. So as you can see here, it looks like the second subject was had the highest concentration, and the third subject had the lowest. When we did the study, the bioharness had issues connecting to the sensor and connecting to the heart rate. And so the first subject, we actually weren't able to get any heart rate data at all. And also for the second and third subject, the bioharness wouldn't lock onto the heart rate for the entire day, so the data is pretty sporadic. But what we were able to see is that the average time in between each heart rate interval was about 114 milliseconds for the second subject and 164 milliseconds for the third subject. And so that is time in between each successive heartbeat. And what we want to see is high variation in that number that contributes to better cardiovascular functioning. This table is a breakdown of each sampling day for each subject, and the Partector measures ultrafines in the number concentration metric as well as lung deposited surface area and mass. And so I wanted to highlight that here and see maybe which days they were more exposed or less exposed, and if that showed anything in the heart rate variability data. So this is similar to the table in the last screen, except we did them as plots instead. And these are the 3 different metrics that were used. So the big one in the middle, this is the number concentration broken down by subject. So this big red spike, we can see that the first subject had a much higher number concentration compared to the other 2 subjects. However, if we were to look at the other 2 metrics, lung deposited surface area and mass concentration, it looks like the third subject was more highly exposed to those. So that could allude to, if we look at the heart rate data, which metric maybe corresponded to these better. So what I saw basically from the data was that the second subject had their lowest heart rate variability data was on day 2, but it also corresponded to the lowest ultrafine particle exposure for that day. So you can see that here, which is kind of opposite of what we were expecting. And also the third subject on day 1 had the highest heart rate variability values, but also the highest ultrafine particle exposure levels. So again, opposite of what we were expecting. However, when we looked at the overall weekly particle exposure, subject 2, who was male, had the highest overall particle number concentration exposure for the whole week. And overall, he had the lowest heart rate variability. So this is consistent with what the literature shows, though we don't know if it was significant or not. A lot of the literature points to decreases in heart rate variability with increased exposure to particulate matter. And again, low heart rate variability is an indicator of decreased cardiovascular functioning. I quickly did some correlations, and we saw that number concentration and lung deposit surface area of the ultrafine particles were well correlated. Again, which is similar to other studies, though our results were a little higher. Particle number concentration, however, was not correlated to mass concentration, which again is similar to other studies. So with that, I'll just briefly touch on some of the limitations of the study. First and foremost was COVID delays. We were wanting 30 subjects. We only got 3. And so because of that, we weren't really able to draw any complete associations or run any statistical analysis apart from descriptive data. So hopefully with more subjects, we can look into that further, which led to a smaller sample size at this point. And also the Smartia device, which measured PM 2.5. We had issues charging that device. A lot of the subjects were unable to charge it for the week. So we have about 1 day's worth of data from that. So I'm not sure if it's usable yet. And then the lack of the bioharness data just from problems with it connecting to the heart rate. And again, there's not enough power in the study to determine if there's actual associations with heart rate variability and ultrafines. So for the future direction, we hope to continue with data collection if we can, and get the rest of the subjects, and then also look into those correlations between the heart rate variability and the various metrics. And then as of recently, we were able to get an algorithm in order to determine the microenvironments using the GPS data. So that's another thing that we can look at in the future and see which microenvironment gives us higher ultrafine particles. However, one of the benefits of this study was we were able to establish some partnerships with home health care agencies, so specifically ProHealth and Ohioans, that we can use for this study, as well as for future studies in the ERC. And again, there's no literature on particulate matter exposure in home health care workers. So this is the first study to kind of look through that. So just some of the things that I learned from this pilot project was mainly grant writing and submitting it, and going through IRB, developing the protocol and submitting that, going through a budget, purchasing, going through REDCap, learning REDCap, recruiting through REDCap, and then also organizing multiple aspects of the project at once, and as well as developing those partnerships. So with that, I'd like to thank the NIOSH for the PRP grant for allowing me to collect the data that we got, as well as my mentors, Dr. Raponen and Dr. Ryan. And with that, I'll take any questions.